Good morning. Today we are in Madrid at the European Multiple Myeloma Academy meeting. This is a meeting that is supported by an unrestricted grant from Celgene and Amgen and is organized by the University of Navarra. And today is my pleasure just to discuss with you about new tools for treatment monitoring in multiple myeloma patients. And we have three distinguished speakers. And please, would you mind to introduce yourself, Michele?
Michele Cavo, Bologna University School of Medicine.
Hervé?
Hervé Avet-Loiseau, University Cancer of Toulouse, France.
Bruno Paiva, University of Navarra in Pamplona, Spain.
Okay. Some people may think that the new diagnostic techniques are expensive. At the same time, they are much cheaper than just one cycle of treatment. And probably with a new tool for make more accurate diagnosis, you may improve the assessment of the disease, the monitoring of the disease. Do you agree on that? In other words, do you think the new tools for diagnosis and monitoring should be rapidly implemented in almost every center?
Yes, my answer is yes. I think that now, for example, discussing the evaluation of myeloma bone disease, we have no specific tools that are clearly superior to conventional X-ray in detecting bone lesions, in evaluating bone marrow plasma cell infiltration. So these tools should be applied at diagnosis not only to more carefully identify those patients with a myeloma requiring event and the need to subsequent therapy, but also as prognostic markers predicting for the subsequent outcome of the disease. So it is my routine clinical practice to perform in every patient who is treated with any of the novel agents MRI of the spine along with the total body PET-CT.
Okay, I will come back later on to the imaging technique, but let me now ask both Hervé and Bruno, and also with Michele, we have new diagnostic criteria and now new response criteria that has been just published, and they include the minimal residual disease evaluation outside the bone marrow with a PET and inside the bone marrow with either flow or NGS. The question will be, which one of the two techniques are both of value? Should you include this evaluation in routine clinical practice for better monitoring of the patients? Yes? No? Please.
So yes, definitely I think that evaluation of minimal residual disease is very important. First, we have to say this should be restricted in patients who are in complete remission. Electrophoresis is still the standard of care for monitoring the patient until complete remission. After that, many people, as you said before, said, oh, it is very expensive, we should not do. I hate this kind of question because when you see the cost of the drugs, I don't think it is really expensive. But it is not expensive if we can spare some therapeutic resources. And so far, I don't think we are able or we should not use MRD evaluation to adapt treatment of the patients. We have to demonstrate this is a surrogate marker for survival in prospective clinical trials, but I would say it should be done in all the clinical trials. After, for technique NGS, NGF, I think the sensitivity is almost the same. Many trials are comparing both. I'm not sure that one will be superior to the other one.
and probably the decision will be adapted to each lab. I mean, similar to other medical decisions that each lab will be more comfortable with one or the other, and this will.
Well, I fully support what has been said before, and I would just like to echo on the fact that this is really a change in paradigm, and the quality of the complete response. And again, reminding that the MRD assessment should be performed on those patients in complete response. The quality of that complete response is now probably better than it was a few years ago, and this implies that those MRD tests that were being performed a few years ago, while of prognostic value, I'm afraid that currently they could afford some false negative results because the levels of MRD have gone low due to the fact of the efficacy of the new treatments. And therefore, I would really like to emphasize that while it is becoming more and more adopted, the assessment of MRD, it should be done with validated and very sensitive methods, otherwise it might not be informative. And again, information is a key word, even though outside of the clinical trial there is at the moment no information that should help guiding treatment decisions based on MRD. I think it's valuable information and knowledge, similarly to ISS, cytogenetics, and the complete response. What we claim is that MRD is the next level of complete response, and being more informative should be there as part of the patient workout.
In other words, do you think MRD, by flow, next-generation sequencing, or PET, will become a very important biomarker in the near future, or is already one of the most relevant biomarkers to assess the quality of the response, the depth of the response, the efficacy of the treatment? Do you think so?
Yes, I think now, at least for young patients, we are in a period where we can expect to cure a significant proportion of these patients. And so cure will be defined by absence of any sign of disease in the bone marrow or outside of the bone marrow, and patients should be out of any treatment to say they are cured. Do we have to wait 5 years, 10 years? I don't know. But I think that it should be, at least for young patients, the main objective of the clinical trials.
Today in the debate we had been talking about the interpretation, and I think all the panel agree that to have MRD positivity means that you have residual disease, and this is bad. By contrast, when you are MRD negative, this can be good, but at the same time, due to the pattern of the bone marrow infiltration in myeloma that is not uniform, it could be that the sample that you are getting is not representative enough. Then I think this is relevant for the patient, because if you are MRD negative, it's much better than to be positive, but at the same time, you need still to have some precaution, because this does not mean that you are cured. Michele, let me go back to the imaging technique. Most centers continue to do the conventional X-ray, but to do a good exam with conventional X-rays, you need 14 X-rays, if I am not wrong. And the sensitivity is low. You need to lose, I was told, around 30% of bone substance just to have a lytic lesion that identified as a bone disease.
Even more, up to 50.
Up to 50. Then this can be easily replaced by the CT. Is correct?
By sure, I think that at this time, the current IMWG recommendation is to perform whole body CT as a standard evaluation of bone lytic lesions. However, as previously discussed, it is important to not only evaluate the presence of bone damage, but also the bone marrow plasma cell infiltration. And in this context, the new functional techniques such as MRI and PET-CT may be of value with two different endpoints. MRI is the best tool for assessment of bone marrow plasma cell infiltration and for evaluating different patterns of infiltration. By the opposite, PET-CT is a good technique not only for the detection of lytic lesions seen on the CT part of the examination, but also for evaluating the plasma cell infiltration, with probably the exception of those patients who have a diffuse bone marrow pattern, and in these cases it is likely that PET-CT is inferior in comparison to MRI, but also the sites of FDG avidity as a tool for evaluating the prognosis of the patient.
Let me see if I have interpreted correctly. I'm thinking now in the audience, particularly in the patients that will follow the program. Instead of having the 14 X-rays, you will recommend a CT for the lytic lesion, just to see the bone. And on top of that, you are recommending another studies just to analyze the plasma cell infiltration that does not represent only the lytic lesion, but also the activity of the myeloma. And this can be done with the MRI that detect the plasma cell infiltration, or with the PET, the second part of the CT PET, the PET that will give you the information of the metabolic activity of this plasma cell infiltration. Is this the correct interpretation?
Yes, I think that it's important to emphasize that the first objective is to avoid to lose a patient who need to be treated. Therefore, to have a misdiagnosis of a myeloma defining event. In this context, X-ray may allow to have an under-evaluation, and based on this, the strong recommendation is that every patient should receive a whole-body CT. MRI and PET-CT are complementary techniques that may offer important additional evaluations in terms of biology of the disease, in terms of prediction of subsequent outcomes, and so on.
Okay, final question for all the three. We have minimal residual disease, evaluation inside the bone marrow with the next generation sequencing or next generation flow, outside the bone marrow with the CT PET. Do you think these techniques will help also to speed the registration of drugs in the future by assessing as an endpoint to be MRD negative and not to wait for overall survival, which is becoming more and more difficult because due to the high activity of the drugs, patients need to wait many years. Do you visualize this?
At this time, there is a huge effort to consider and to convince the agencies of the importance of MRD negativity as an early biomarker for the fast-track approval of new drugs.
How do you see?
I agree also. We have many meetings with FDA to try to show them that MRD evaluation and CT PET is important to be a surrogate marker for overall survival. We need to have a little bit more follow-up of the patients to be sure, but I think we are presenting good data showing that. And so I'm pretty sure that in the next 2 years it will be approved by the agency.
Definitely, and I would echo the data. I think is already been there suggesting that it might be used as a surrogate marker, but we need more follow-up, particularly with the new methods. Once we get there, I'm confident that the data will continue to support the use of MRD as a predictor of outcome and hopefully to help novel drugs to be sooner available to the patient.
Okay, Michele, Hervé, Bruno, thank you very much for the time, and I hope this discussion has been of help for the audience. Thank you very much.